Welcome to this Prader-Willi Research Foundation Australia family webinar. My name is Dr. Diane Webster. I'm the Research Director for the Foundation, and I'd like to thank you all for taking the time to join us this evening. I'd like to hopefully get the slides working. There we go. I'd like to acknowledge the traditional owners of the land where we're meeting. I'm dialing in from Wurundjeri country this evening, and I'm sure we're calling in from all sorts of different countries around Australia. I'd like to pay my respect to the elders past, present and emerging, and acknowledge the long and enduring connection to country for our First Nations people. We welcome all First Nations people tonight, and thank you for joining us. A little bit of housekeeping to start with. So we're running on Teams. Teams has a live caption facility if that's something that's useful to you. You can use the hands up button later on. And of course, there are reactions if you want to share those with us through the night. We're going to be running questions through Q&A, so feel free to pop your questions in there at any point in time. Now, the Research Foundation was started for the single purpose of growing research in Australia, and our goal is to change life for Prader-Willi syndrome for the better. And we've developed this research roadmap, which is to help ensure that everything we do is focused on achieving that goal. This evening, we have 3 fantastic speakers lined up. We're expecting we'll run to about an hour and a quarter tonight, so we should be finished well before 9:30. Our first speaker tonight is Dr. Maryssa Portelli from the Royal Prince Alfred Hospital in Sydney. Psychiatric care is something that's critically important for people with Prader-Willi syndrome. Dr. Portelli is a staff specialist psychiatrist working in the Prader-Willi syndrome clinic at the Royal Prince Alfred Hospital. Tonight, she's going to guide us through what we need to know when we're presenting to the ED for mental health issues in Prader-Willi syndrome. You can put your questions for Dr. Portelli into the Q&A. We'll do a bit of Q&A at the end, and just please remember that this is a webinar format, so Dr. Portelli will only be able to answer questions in a very general sort of format. Dr. Portelli, we're really delighted you could join us this evening. I shall pass over to you.
Thank you so much, Diane, and thank you everybody from the Prader-Willi Research Foundation for inviting me today. I'm, I think, fairly new to contributing to the Research Foundation, and it has been just such a really welcoming experience. So thank you, everyone, particularly Kathleen and Diane. As Diane said, and I'm hoping that everybody can see my slides okay, I'm a staff specialist consultant psychiatrist at Royal Prince Alfred Hospital. I was a developmental psychologist. I then went to medical school, trained in general medicine, then did psychiatry, and then, because I'm a glutton for punishment, trained in consultation liaison psychiatry, which is kind of psychiatry of medical conditions, and I did a heady fellowship in intellectual disability, specifically on ways to reduce basically the side effect profiles of all the medications that people with intellectual and developmental disabilities get put on. Now, really, really recently, we've been given a grant from Sydney Local Health District and New South Wales Health to improve or enhance the Prader-Willi Clinic Metabolism Obesity Service at Royal Prince Alfred Hospital that many of you will know. That's where Professor Markovic and the wonderful Georgina Lachlan are, and to have a psychiatrist. So we are now in a role doing that. So the other kind of crossover hat is that I'm head of emergency psychiatry for Royal Prince Alfred Hospital. It's an extremely busy emergency service. I see or have discussed with me about 600 patients a month, and a lot of those are people who have developmental disabilities, Prader-Willi, various other rare diseases. And so actually creating a pathway for people to be seen effectively and appropriately and in a disability-informed way is a really big part of what we do. I'm also a mum, and there are my two crazy children on the screen. If you hear them during this review, I apologize. It's 8:10 in Sydney, and my husband is trying to get them to bed. So you might hear some little voices along the way while I'm here. So I'm going to start talking about the emergency department, because for anybody, it's a pretty terrifying place. It's loud, it's fast, it's unknown, it's unpredictable. And for somebody with Prader-Willi, that is particularly terrifying. And for parents of somebody with Prader-Willi, it really is a nightmare scenario, and no one wants to go to the emergency department if they can absolutely avoid it. And then added to that is that you've got lots of people who don't actually understand what Prader-Willi is and don't understand what we actually have to take into consideration, and what we have to have front of our minds differently to other populations when they come to ED. And nobody in the audience will be surprised by any of these things. But I guess off the top of my head, these are the things that I have to have in my mind whenever somebody calls me and says, we've got John Smith here, he's got Prader-Willi and blah, 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 blah. These things is what pop into my head, but it's not necessarily what's going to pop into the average junior doctor. Now, the emergency department, particularly after hours, and we know that that is when the majority of crises happen, are staffed by really junior medical staff. And whilst we are trying to skill up as many people as we can, and at Royal Prince Alfred Hospital, we have between 10 and 12 trainee specialists, so across endocrine and psychiatry, who are coming through our clinic, who will be coming through our clinic soon, a year, trying to skill up in Prader-Willi. The vast majority of junior doctors will never have heard of Prader-Willi. They're unlikely to understand about the autonomic instability, the pain, the abnormal pain response, constipation, hypothalamic issues, and they will miss things. So from this talk, I have compiled a list of resources that I think are really helpful if you're going to go to the emergency department. And one of them is the Ipsos, what is Prader-Willi syndrome and what you have to look out for doctors. It's quite a short document. It's something that the link is on the last slide, and it's something that when you have kind of your folder of things, it's a really good upskill document for the doctors in front of you. My second thing is that as parents and carers, unfortunately, sometimes you have to be the experts, and that's not necessarily fair. But in all rare diseases, often the patient ends up having to be the expert in their own thing, and carers have to be. So I wanted to talk to you a few of these things. I think a lot of you would be aware of this, would have experienced things with this, but they're kind of alarm bells to have as a carer when a loved one becomes sick. So the first big kind of overarching thing is hypothalamic dysfunction, and the hypothalamus is a structure right in the middle of your brain, and it controls basically lots of the regulatory functions in the body. So because of the hypothalamic dysfunction that we know that everybody with Prader-Willi has, not only do you get the hyperphagia, but you get this high pain threshold. So if somebody with Prader-Willi is saying that they have pain, I really believe that they're in pain. But often they can't localize that pain. It might be, I'm in pain, I'm in pain, I'm in pain, and actually they're constipated. They get poor temperature regulation. So we get, spiking fevers when there's no infection. We get no fever when there's raging infections. And that can be really dangerous because a lot of, doctors in medical school are told, look for the fever. All of the structures we have around the escalation criteria for sepsis are about fever, and that doesn't apply to somebody with Prader-Willi. We also need to think about hyper and hypothermia. Often people with PWS won't feel cold. There's been quite a few cases of going into hypothermia because they've worn inappropriate clothing in really cold situations. More so in the US and kind of North America, do you see these cases than Australia? It's generally not cold enough here to do that. We also see people coming with burns because they've eaten or drank food. They get burns on their hands, burns on their mouth, because of that lack of awareness of temperature regulation. Lack of vomiting, which I'm sure you're all aware of. So, if somebody's got a small bowel obstruction, one of the things that we look at usually is, are they throwing up? Are they throwing up? Often people will even throw up water in a small bowel obstruction. Doesn't happen in Prader-Willi. We also have to think about the abnormal body composition, and the increased adiposity, so the increased ratio of fat to muscle, actually completely changes what dosages of medications we use and how they're absorbed by the body. A lot of the medications we use are fat soluble, and so that actually changes things. So you might need less medications. For certain medications, you might need lots more medications. You're far more likely to have side effects from medications. And then some medications might not work at all. And I'm going to talk about that a little bit later. There's also the gastroparesis and decreased gut motility. And, that's about constipation. And the first thing I order, if I'm going to order any test on somebody who comes in with PWS, is an abdominal X-ray, because constipation can lead to 101 different problems, and often things that look like they can't possibly be related to constipation, but actually it's the core cause, and you can fix things really quickly just by getting somebody's bowels moving. We also have probably one of the things that in an acute setting, when we don't have all of the supports around somebody and they've walked into the emergency department, one of the hardest things as a clinician to cope with is confabulation. So I think almost every person with Prader-Willi I have ever met has had a degree of health anxiety. They jump to conclusions. They can misinterpret treatments that they've had. Often they might tell me something like, oh yeah, I had my thyroid removed. And you'll look at mum or dad and they'll be like, no, that didn't happen. They'll say, oh yeah, no, I've had lots of broken bones. And you'll look at a carer and they'll say, no, that didn't happen. And that's about manifestation of anxiety. And so when you're trying to get a history from most people with Prader-Willi, you kind of have inclusions that some things that they suspect happened or thought happened, but isn't necessarily what actually happened, or a sprained ankle might actually be interpreted as a broken leg, that kind of thing. And so it's all health facts need to be verified. And so more so than even other developmental disabilities, with PWS we really need kind of reliable carers who've known the person for a long time, because otherwise things get entered into a medical record that never happened. I'm just having a look at, there was a comment, sorry. About, yes, Tina, absolutely, about not doing about PWS, and what we are trying our best, but it's a work in progress to upskill people in PWS. Now, skin lesions, really common sign of infection. So develop folliculitis, that becomes cellulitis, often bruise easily. One kind of horrible thing that I think we're better at in our children's hospitals in Australia, but in the US, often kids with Prader-Willi, it's suspected that they're being abused because they've got bruises all over them, but it's because they bruise easily. But also skin picking is often a self-regulation strategy, so it's kind of what they do to calm themselves down. I would say psychosis, because that is suspected psychosis is a really, really common reason why people come to the emergency department with PWS. It's almost never psychosis, can I say? And I will go into that later as well. But the thing that I kind of really want to talk about more today is delirium, which is for those who don't know, is a temporary alteration in mental state that can look like psychosis, but is caused by physical illness. And it can be caused by constipation. It can be caused by electrolyte abnormalities from medications. It can be caused by dehydration. It can be caused by 1,001 things. And it's really what gets missed in people with Prader-Willi, and can be life-threatening. So I think as parents, as a group, this is a really good thing to be aware of, and if you do have to take a family member to the emergency department, say what about delirium, what about delirium, what about delirium? Because when I get the phone call at 2 o'clock in the morning about somebody with Prader-Willi who's turned up to ED, my answer is, my question to the junior doctor calling me is always, what about delirium, what about delirium, what about delirium? Maybe next. Okay, so I wanted to touch on why is there such a disconnect between the doctors in emergency, the carers, even great NDIS still carers, and kind of what we need for the person. And really is that there is a huge system issue. Whilst the NDIS has had lots of positives, a big negative is that it has forced two systems, one primarily funded by the states and one primarily funded by the federal government, to not talk to each other. There is absolutely no overlap. So from a health sector bias, and I have to say I was guilty of this too before I started working in the intellectual disability space, is really misunderstand what the NDIS does. Is that we think group homes are going to be more like nursing homes and they can do medical treatments. We think that disability workers are going to be as skilled up as healthcare workers, which of course they're not, and that they're going to manage medications and they're going to be able to manage dressings and chronic health conditions and checking blood sugars and all these things. And 9 times out of 10, they can't. And certainly mental health services Australia-wide do not see developmental disabilities as their core business. They will not pick up people back. And this is people with autism, people with ADHD, people with intellectual disabilities, people with every genetic syndrome you can think of will be palmed off. And if they get palmed off, what service picks them up? And that's probably the crux of where this lack of education comes from, because nobody considers it their core business. On the disability side of things, probably the biggest thing I come across is as a psychiatrist when I'm prescribing medications for someone that is for treating an identified condition, I get, you can't do that, it's chemical restraint, it's restricted practice. And it's not, but there is this fear of restricted practices. Often there is this over-reliance on very cookie-cutter behaviour support plans. Behaviour support plans can be a bit hit and miss. There are some excellent ones, but there's also ones that look like they've just cut and pasted. When I look at probably dozens of behaviour support plans, if not hundreds of behaviour support plans a year, and you can see which ones have actually cut and paste off each other, but then you can see the ones that are actually really good. And there's also this idea that any risky behaviour that's happening must be a mental illness. And the majority of the time it's not. And there is this idea that the hospital can fix things. They can fix accommodation, they can fix the risk management, they can just fix it. And majority of the time, unless there is a physical disorder or a physical condition that needs to be reversed, the hospital is often the worst place for somebody with PWS to be. And as I kind of talked about before, there's this lack of capacity, is that the majority of doctors don't know what PWS is. If they do know what it is, they lack confidence because they haven't had formal supervision. They haven't had people they haven't had, been handheld through it the same way that they get held through diabetes or cancer or, kidney disease. They don't know how to treat people with developmental disabilities at all. And they often will attribute symptoms as behavioural. And I'm sure there's lots of people in the audience who've come home from the emergency department told, oh, no, it's just behavioural, or it's just their PWS. But this also happens in kind of the disability support thing as well. It's that symptoms attributed to as behaviour. So before I go into that, I wanted to outline kind of what my gold standard ideal is if somebody comes into the emergency department. I love communication folders. I take time to read them. Not every doctor does. The emergency department is really designed to treat life-threatening situations and then push you on to the next part of your journey. So if the doctor in front of you doesn't read the 80 pages that you've brought with you, please don't be offended. It's that they're expected to see 5 patients an hour. When the psychiatrist comes, we should be reading it. Medication charts, behaviour management plans, proof of guardianship and who can make decisions for the person, or if they're perfectly able to make decisions on their own, if they need just some supported decision making, that's really good information for us to know. A favorite item or distraction items. iPads are wonderful for the emergency department, and headphones are wonderful for the emergency department. And a hospital support plan. So I've just included on here, and there's links to all of these at the end of the talk. The A2D is my favorite as a communication folder with healthcare professionals, but the My Health Matters and the CHAP is also good. But they are all easy things to fill out. I like the A2D because it actually encourages the consumer themselves to fill out parts of it and have their voice through. And often when, I'm trying to get the person on side, it'll tell me a bit about them and what their interests are. And, we can talk about some other thing that I like to do. We can have a whole conversation about Lego or My Little Pony or something like that, just to kind of help them get at ease about what is quite a challenging environment. And the other thing is a hospital support plan. Now, the A2D has a really good one. It's only a few pages long, and it's basically a summary of all the stuff that is pertinent to that person coming into the emergency department. And here is just an example of that, is the questions about communication needs. So really common one for Prader-Willi: can the person communicate their needs, including pain? And the answer might be no, level of risk high, support level 4. And what we would write in the comments for that would be that people with Prader-Willi have difficulty localizing pain. A negative response to "are you in pain" does not necessarily mean they are in pain. They need further investigations. And that's going to actually inform the doctors. They're not going to just write it off. Oh, no, they can't have a bowel obstruction because they're saying they're not in pain, which is a really big pitfall. The other thing is preparation for the patient. And what I ask is that when your child or the person you're caring for is well, we do some training and going through some of the very many easy read guides that there are about preparing for hospital. Now, this one that I've screenshot there is the New South Wales Health one. But almost every state has one. I've put some links in again at the end. So when they're well, we know that people with Prader-Willi have trouble sequencing verbal commands, and we know that giving them a whole lot of verbal information and asking them a whole lot of questions is just going to make everything feel really overwhelming. Pictorial representations that you can go through slowly, you can refer back to, is actually the quickest way that you can of having this is what to expect. And of course, we all know that having routines and having set expectations is a really great way of putting somebody with Prader-Willi at ease. So I like to give all my clinic patients one of these, go through it, have an idea, and then they have a hard copy with them. And when they come to the emergency department, they can say, oh, okay, this happened. I knew this was going to happen. There's a whole section on blood collection. There's a whole section on having an x-ray done, so that if those things happen, then there can be an awareness of, okay, this was the next step. This is what I expected would happen when I came to the emergency department. And it does make the process far less scary. And Lucinda's just said that she did the New South Wales Health Guide for operations today to prepare for a procedure on Monday. Perfect. That's exactly what I want to hear. It means that all the effort we put into making these things wasn't for nothing. So the other thing is that it is completely reasonable that when you've got somebody with a disability, when you arrive in the emergency department, that you have a list of requests. If you can have consistent staff, and there is actually provision in the emergency department for this. I know they're very busy, but it actually makes everybody in ED's life easier if they have consistent staff, one-to-one staffing if possible from the beginning, single room if possible from the beginning. And I would actually recommend, given the waiting times in ED, asking for a little bit of medication to calm the person down. Now, I've just put on here, usually it would be a very small amount of lorazepam, not enough to make them fall asleep, but enough to kind of bring down some of that sympathetic drive so they're not panicking, they're not jumping at every little noise, or a small amount of typing is another option. But there is an expectation that you're probably not going to be seen within 5-10 minutes. Having something from the nurses is a really good idea at the beginning of coming in. We're really, really lucky in RPA that they've been so receptive about us making policies about Prader-Willi, and I'm absolutely not taking credit for this. This predates me, and there are people in the audience who actually contributed to this. So all of the kudos of this goes to the Metabolism and Obesity Service at RPA, but we have a mandatory policy on how to manage individuals with Prader-Willi when they come into the emergency department. I would love if this was rolled out all over the country. I don't have that much faith that it will, but I would love if it was. So when somebody with Prader-Willi comes to RPA, and I've put this policy, again, the link of it at the end, is that they call the endocrinologist on call. This is regardless of what they came in for, but endocrinologist still needs to know that they're here. All people with Prader-Willi get as Georgina's just said, the RPA policy can be shared throughout Australia. I've put the link in the end. So if you want to give it to your local hospital or put it in with the documents for when you go to hospital, I think that would be an excellent idea. They need a single room. I think that's a no-brainer. They need a low energy diet with 20 grams of fat. They need no access to sugar, no access to snacks off the trolley. The lady can't come around 5 times a day offering them strawberry milk. I think that's all no-brainers. And yet, when I consult on people who are in other hospitals, because Georgina, Tanya, and I do take phone calls from all over New South Wales, that's exactly what's happening. The staff tea room has to be locked. They can't know that if they go 5 steps that way, they can access all the biscuits and tea and coffee and sugar that they want. If they're going to be there for more than 24 hours, they need an occupational therapist to come and work out what distraction techniques they can do. Because a bored PWS is a frustrated PWS. And we always need a responsible carer or parent to be present. And every state actually has an agreement with NDIS about a shared care view of NDIS providers coming into the hospital. Now, this bit is also in the Prader-Willi guideline, the RPA guideline. And I think this kind of gets around this junior doctors not knowing what Prader-Willi is if you've got a policy that says, no, you got to look at this. Fear of pain. Always use anesthetic cream. I always give a little bit of lorazepam before I make my PWS patients go through injections. Not that hard. It might delay doing the blood test by 20 minutes, but it means you're not going to have a highly distressed patient in front of you. Close monitoring for constipation, not just relying on self-report, not just relying on maybe they've opened their bowels. I have a really low threshold for doing abdominal imaging. I think it's really, really important. And I have to say, every time I've done abdominal imaging on somebody with PWS, they've had overload of constipation, which is going to impact everything else. We have to be aware of sequential processing deficits. So as I said, having pictorial representations. The big thing, and everybody finds this frustrating in ED and in the hospital, and it's extra frustrating for someone with PWS, is trying to avoid differences in the way that instructions and procedures and processes are explained. If you've got the night nurse saying, oh yeah, you can do X, Y, Z, and you can bring external food, and you can do this, and I'll take you for a walk, and we'll do that. And then the 7 o'clock nurse goes, oh no, I'm not doing any of those things. We get a meltdown. And that's a predictable meltdown. If we have somebody who says, oh no, you have to fast because you're doing an ultrasound at 9 o'clock in the morning, and you've gotten to 2 o'clock in the afternoon and it still hasn't happened, you're going to have a meltdown. And we have meltdowns for these reasons from patients of all walks of life. It's not just PWS, but it's more predictable that it's going to happen with someone with PWS. We need quiet, calm, and confident speech. If you've got a junior doctor staring at their toes and mumbling at you, we're not going to get anywhere. And I mean, one of the most resilient and lovely things I find from all my PWS patients is that they have cracking sense of humor. If you can go in with a bit of distraction and a couple of jokes, that actually half the job is done. And just kind of being aware of that, of just going in. Sometimes it's, sometimes it can be the silliest joke you can possibly think of. And even though they're feeling a bit miserable, you'll get a pretty good chuckle out of them. And then suddenly you've got somebody who actually wants to listen to what you're saying. So a lot of the training that I do with my registrars is about kind of injecting humor into a psychiatric interview. He didn't have PWS, but I met a lovely 96-year-old man who the surgeons thought was suicidal the other day, who his therapy was that he had to think up a new joke for me and for me for the next time I had to visit. And I told him that if he could come with a not safe for work joke, that was fine. I would take that. And he did. He would rack his brain for the funniest joke he could possibly make up me to see the next day. It's really, really important to have that rapport and actually have that ability to not take all of this so seriously, because it's scary enough. Behavior disturbance. So about a quarter of people who come to ED with PWS, behavior disturbance will be recorded as the reason they came to hospital. And this is my great big bugbear that I get very, very angry about, not at families, at the emergency department. Prader-Willi is not a cause of behavior change. It can be a cluster of behaviors. It can be a phenomenology of behaviors. It can be established behaviors. It is not a cause of acute change. So if your child or the person you're caring for has completely changed in the last 2 or 3 days, they're withdrawn, they're not eating, they're not being their social funny selves, that's not their Prader-Willi. And yet I see so many cases where the families have been chucked out of ED going, oh yeah, just go back to your NDA support. Here, have some olanzapine. And it really is something that upsets me greatly. So, which is why I think I had to talk about it today. These are, off the top of my head, some things that can cause behavior change that are not Prader-Willi. And they can be your blood sugars being too high. They can be constipation. They can be sensory impairment, so not being able to see properly or hear properly. Heart conditions, pain, chronic pain. So joint pain is another thing. We see lots of people with Prader-Willi with joint pain. Sleep apnea, medication interactions, thyroid diseases, vitamin deficiencies. All of these things are better reasons for behavior change than the fact the person has Prader-Willi. And when somebody gets referred to me, because I would like to think referring to psychiatry is a process of exclusion, but when someone gets referred to me and they've been in the department all of 5 minutes, this is something that I reiterate to the team, is that we only diagnose a mental illness when we exclude everything else. It is a diagnosis of exclusion. We have to think about everything else that's going on. And if we label it as mental health, we will miss the medical problems. We will miss the drug interactions, which is my research area. We will miss the changes at home or potentially the abuses that are happening at home. We will miss from different settings. We will miss the staffing, how the staffing changes are impacting that person. We will miss losses and deaths that may be extremely significant to that person, but we don't even, it's not even on our radar. And we miss who that person is by giving them a mental health label. And I'm very reluctant to give any of my patients a mental health label based on an ED interaction. If I get a phone call from a registrar saying, I've just met this person with PWS and I think they have schizophrenia, I say, take it off their file. Because you cannot diagnose this by meeting somebody for 10 minutes. I usually would see somebody at least 3 times, usually more, and spend a significant amount of time talking to all the other clinicians who'd looked after that person in the past before giving somebody a diagnosis of a mental illness. Now, as I said before, have delirium front of mind. So all of those things I talked about, all of those medical conditions can cause delirium. And delirium can be scary, but the wonderful thing about delirium, or the optimistic thing about delirium, is that it's reversible. By definition, it's reversible, particularly in a young person. So before we jump to this is psychosis, this is bipolar, this is schizophrenia, this is OCD, this is whatever label we're going to go to, I want to know if this is something I can reverse. Because we don't cure mental illnesses. And any psychiatrist will tell you this. Mental illnesses are with you forever. You can go into remission. We can cure constipation. We can cure an electrolyte imbalance. So I want to know, is there something curable before I add a label to what is probably already a shopping list and put somebody on a medication that they may need to be with side effects, which they may need to be on for the rest of their life. So you can see on here, there's a lot of overlap between delirium and mental health issues. So you can have hallucinations, delusions, preoccupations with strange ideas. The most bizarre delusions that I hear in the hospital setting aren't from my patients with schizophrenia. They are from my patients with delirium. My patients with schizophrenia, none of them have ever told me about green aliens coming from the ceiling, but my patients with delirium have. Now that happens in hours to days. In contrast, if we were going to give a diagnosis of typical schizophrenia, that usually happens over 2 years. So it's a very, very different picture. I would be remiss if I didn't talk about cyclical psychosis in Prader-Willi. It's something that Tony Holland is doing a lot of work on at the moment. But as I put in this kind of Venn diagram, it crosses over with a lot of things. And it's extremely hard to distinguish from delirium. And kind of, as I said before, I would want to know that what was happening in front of me wasn't reversible by changing a medication or managing or doing a blood test or managing constipation before I would label that as a mental illness. And as I said, psychosis is a diagnosis of exclusion. When we do have somebody come in with behavior disturbance, the first thing we do is look at the non-pharmacological management. And there are quite a few good behavior support practitioners who can do this. And a lot of it is common sense just by knowing that person. Sleep hygiene is going to make a really big difference. Having well-occupied days is going to make a really big difference. Going to day programs, having community engagement, doing things that are interesting all day, you're going to sleep better at night. If there is very little difference between you staring at a wall during the day and you staring at a wall at night, you're not going to get a good night's sleep. And that goes for anybody. And we want social interactions. We want them to go to bed physically and emotionally exhausted because their day has been full of things. That is going to do much better than any antidepressant that I can give them. We need predictable and consistent food schedules. We can't have carers in SIL programs switching out ingredients or changing things. We need that routine because that's a big trigger for behavior disturbance in the patients that I see. Behavior support plans, if any a behavior support plan covered in the NDIS is an absolute staple for anybody with Prader-Willi. Every single person with Prader-Willi should have a behavior support plan and regardless of their level of intellectual disability, even people with Prader-Willi with normal intelligence should have a behavior support plan included in their NDIS. The medication for behavior disturbance is a restrictive practice and it should only be a short-term solution. So it is very common that I see people on escalating amounts of antipsychotic that were started maybe 5 milligrams of olanzapine D. They went back to the GP, went to 10 milligrams, went to 15, went to 20. And by the time I see them in clinic, they're on massive amounts of antipsychotic that we would really only use for treatment-resistant schizophrenia in the general population. And they're being used on somebody who's actually never been psychotic in their life. The other thing I wanted to talk about briefly is about Australian prescribing and the PWS and PWS. This came up recently at the Asia Pacific conference because a lot of the American data and the UK data, our prescribing systems are different. So even though medications may be approved by the Therapeutic Goods Administration or the FDA, or Food and Drug Administration in the US, which you would think then we could use, we are then a bit limited by the PBS in Australia. Doctors will often say, oh, it's not on the PBS for that indication, I can't write you an authority, but we can write things off label. Now, what that means in real terms, one good example is growth hormone, is that there are specific parameters for prescribing growth hormone, for an endocrinologist to prescribe growth hormone that people with PWS may fall out of, but they can still access the growth hormone on a private script. It means that you don't get that medication for the subsidized rate. You have to pay what the company is selling it for. So it can be very expensive, but it is a way of accessing that medication. And some clinicians can be reluctant to prescribe medications off-label if it's not something they're familiar with. And the cost of these non-PBS medications for some can be prohibitive. For others, when you actually look at how much it is, it might be, say, $30 a month. But I acknowledge that adds up quickly when people are on multiple medications. And the other issue we have with the PBS is that PBS labels don't match our DSM-5 or ICD-10 labels. So, for instance, antipsychotics are only on the PBS for schizophrenia. They're not on the PBS for drug-induced psychosis. They're not on the PBS for brief psychotic episodes. They're not on the PBS for bipolar with psychosis. They're not on the PBS for schizophrenia, for schizoaffective disorder, which is ridiculous because they all need antipsychotics. So what you might find is that doctors may say a condition is schizophrenia to access medications, or they may say, look, you're going to have to pay the private amount, not the subsidized amount. So examples of this is something like guanfacine, which has been talked about a lot in PWS. On the PBS, it's only subsidized if it's second line for ADHD, if stimulants were not tolerated and the ADHD had to be diagnosed before the age of 18. Now, lots of pediatricians and psychiatrists will do that, but there'll be others who will say, well, no, by the letter of the law, we can't. You've got to pay the full price. But guanfacine's $45 a month. So for some people, that actually is within financial reach. The other thing we talk about, say, quetiapine, it's only on PBS for bipolar and schizophrenia, but we do use it commonly for insomnia, anxiety, emotional dysregulation, borderline personality disorder. We use it for lots and lots of things, but they're all considered off-label. And I can answer some questions on this because it is a bit of a complicated thing, but it can cause, I guess, some confusion when you're trying to access medications. I can't go into specifics because I don't have time. I don't think you want to listen to me talk about this for 8 hours. If you're going to use medications for mental health conditions, and we know that people with PWS do often have a variant of OCD, they can have a variant of ADHD, ASD, they can have, a type of psychosis that doesn't meet the whole criteria of schizophrenia. So we do use psychotropic medications in those situations once we've ruled out other physical causes for those symptoms. If you're going to use an antidepressant, the one on the left-hand column are the preferred options. The ones on the right-hand column are the ones that are actually very highly likely to cause either paradoxical effects or side effects in people with Prader-Willi. Something that I wanted to raise is that because of the hypothalamic changes and blood-brain barrier changes that people in Prader-Willi have to the general population, it is actually really common to have what's called a paradoxical reaction to benzodiazepines. So that's Valium, Tabazepam, Alprazolam, Xanax. Instead of calming them down, it hypes everything up and makes everything worse. And we actually see that a lot. And unfortunately, because GPs don't understand that, often that means being given more benzos and more benzos and more benzos. And actually, we're just making the whole system completely dysregulated. So one of my take homes today is if you do need something to calm somebody with PWS down, Temazepam, diazepam, alprazolam, please not. If we have to use a benzo, I always use lorazepam. We don't seem to have as much of that paradoxical effect, and it gets out of your system really quickly. So we give them that, they get through the procedure that they need to, and then it wears off. It doesn't hang around, which is probably what's causing that paradoxical effect later. I'm going to open it up to questions now because I think people have lots of questions. They are some resources. I will ask Nicole to send them out. They're all Prader-Willi specific except for the health folders. But just to have a look at, I think preparation is key. That's probably something for every aspect of caring for somebody with Prader-Willi. Preparation is key, routine is key, consistency is key. But all of these resources have lots of great information on that. So I will leave it there. Stop sharing.
Maryssa, thank you so much. First of all, we have been absolutely, the response to the invitation to this webinar was absolutely phenomenal. And it's just been incredible to see everybody engaged in the chat tonight. Somebody, my computer's decided to give me the blue circle of death. Here we go. Maryssa, Dr. Portelli, where have you been for the last 37 years? So I think that sums up how well received your presentation has been. I'm going to open the floor. If people would like to, we did have a Q&A. I don't know if anybody's into that. So if people would like to put into the chat any questions that they have, bearing in mind that Dr. Portelli can't discuss your personal circumstance and specific medications. We just need to obviously be aware of privacy and that this isn't a personal review. Do we have any questions that anybody would like to ask?
And I'm sorry, it was a massive whirlwind.
No.
I did get told by one of my colleagues today that I had to cut out 50 slides. So I did. I had too many things I wanted to talk about. Sorry.
Look, no, Maryssa, I think one of the things that was most fascinating for me to hear just then were, look, there were so many things, obviously, and for a lot of us, we feel like you've encapsulated our experiences in ED and helped us to understand, the challenges that we, both the structural challenges that the hospital faces, as well as, our children and adults' individual challenges. I think one of the things for me is, you talked about the blood.
Oh, it's kind of cutting in out. And blood-brain barrier thing.
And look, there's a general, issue with people with Prader-Willi having a different response to medication, as you discussed around adiposity. Where do we find, if we are in emergency or in any other medical setting with our child, where is there somewhere we can find an easy reference to the types of medications that we should be keeping an eye out for?
That is a very good question, because I went hunting for it because I know what medications I use, and I thought surely there's a guideline that has this somewhere. The best I could find was in Deepan Singh's book. Does have quite a nice flow chart, like decision tree for what medications to use for Prader-Willi, in chapter 11 from memory. I don't know if he's going to let me reproduce it, but it's really helpful. It doesn't go into specific drugs, which I actually think is a good thing because we do have different drugs to the US. But it does kind of talk about drug classes. But I guess something to keep in mind, particularly for antipsychotics and antidepressants, is anything that helps you sleep slows down everything. So things like mirtazapine, Avanza gets used a lot in Prader-Willi, not by me, but by other people. Seroquel, really common, and Zyprexa, which is olanzapine, really common to be used. All three of those medications cause diabetes, cause weight gain, cause constipation, can cause heart problems. They are really, really problematic medications that were never designed to be used for the lifespan and yet get used for the lifespan. And it's to the point that actually in the general population, we now have metabolism and obesity clinics for people with schizophrenia because we're using all these drugs and making them very, very overweight and have lots of metabolic problems. And so you can understand why these medications may maybe not be a good idea for somebody with Prader-Willi. And yet that olanzapine and Zyprexa and Seroquel are the two medications I most commonly are taking people off in the metabolism obesity service. And actually, when Tanya Markovic pitched to me coming to doing this click, she said, "Oh, it's great. You can come here and take everybody off olanzapine." Was my job description, the psychiatrist, to take them off the antipsychotics. And you know what? We have. And, you know, I've got one lovely lady with Prader-Willi who we actually didn't take her off antipsychotics. We switched her antipsychotics because she'd been on them so long. I thought it would be a bit of a shock if she came off. And she lost 24 kilos.
Wow.
So we're not talking about a little bit of weight. We're talking about a big bit of weight, like lots and lots of weight. But I think we've got... Lucinda has said this information will be really helpful when my daughter starts to live independently, especially the communication. Yeah, I really, really recommend the communication folders. The other thing about ED is that shifts change really regularly. Nursing shifts are on a different time scale to doctors' shifts. Nurses work shorter shifts than doctors do, so they don't all line up. So often there's multiple handovers across multiple clinicians. You know, if you're in ED, let's face it, most people are in ED 12 hours. If you're in ED 12 hours, you might switch nurses 3 times. You might switch doctors 2 times. Things get lost in translation. They're trying to hand over 50 patients at a time. Definitely things get missed. But if you've got a folder, and particularly the hospital sheets, if you have that says, we need this, this, and this. They don't respond to pain. They have this. They've had deliriums before. They've had bowel obstructions before. That actually will carry through, and you don't have to be completely reliant on word of mouth, basically, between handovers. So Christy said, okay, yeah, provide the folders with all the information. I do think that as a junior doctor, when they get handed the whole folder, that can be very overwhelming, because they know that they've only got 15 minutes with you before they have to go see the next person. Generously, 15 minutes with you sometimes. That's why I think having a hospital cover sheet as well is good. Like if you can hand them that and say, this is the summary. If you need more information than this, I've got the folder. It's kind of like having, you know, I think a lot of people have worked, you know, in policy and things like that. It's like when you get given a great big legislation, and actually, I just really want the executive summary. So if you can have, often these hospital forms are the executive summary in ED, and then if you do end up at the ward, the people on the ward will have the time, like the endocrine team, the psychiatry team, whoever it is, will have time to actually go through the big folder, which is generally what happens. Yes, and Georgina said the medical alerts booklet. That is also on my list of resources. Thank you, Georgina. And I'm sorry, Christy, that it was a 2-week hospital stay and they didn't go through.
There's a question here. There's a question here about how to explain to the surgeon the possible side effects of anaesthesia with PWS.
There are fact sheets on that. If I can find the fact sheet of you, I will include it in I didn't add it to my resource list, but I can add it to it.
And then around Ozempic.
Yeah.
Is there any thoughts on Ozempic for managing weight loss and hunger?
So Professor Markovic is actually looking at starting a Mounjaro study. It is something that we are looking at. We've kind of had mixed results. And it's kind of one of those watch this space things. So Mounjaro, from memory, has 2 agents in it, whereas Ozempic just has 1. Mounjaro seems to be more bang for your buck, but we do have to look at the gastrointestinal side effects, particularly in people with Prader-Willi. But definitely it's something that is being looked into now. preliminary results from what I have looked at from the overseas trial is that there is some initial weight loss, but it's not sustainable. So we will look at that. This is definitely one of the things that, you know, comes under that repurposing medications, which is going to be talked about in a minute.
And of course, we, Prader-Willi Research Foundation, awarded Professor Markovic the 2023 grant to do that study on Mounjaro or tirzepatide as we've done it. So that's really exciting that she's doing that clinical trial, and that's to look at safety in people with Prader-Willi. All right. I'm looking at the time. Dr. Portelli, thank you so much. I'd reiterate what everyone else has said. It's been a really incredible 45 minutes with you. Thank you. We hope we can bring you back again soon. I'm going to pass to our research director, Dr. Diane Webster now.
Thanks, Kath, and thank you, Dr. Portelli. I'll add my thanks to that as well. Phenomenal amount of information and very, very valuable. Next up, I am absolutely delighted to announce some brand new funding from the Prader-Willi Research Foundation Australia. This project will be joining our portfolio under the treat pillar from the research roadmap. Associate Professor Anthony White is joining us. He's joining from the Queensland Institute of Medical Research, Repurposing. He's going to give us an overview of the project tonight, which he's working on with Dr. Zach Gearing. The project is about the integration or using computational techniques in vitro approaches to achieve drug repurposing for PWS. We're really excited about this project because it uses really powerful and new computer and AI-based approaches to identify potential new drug targets and then match those drug targets to existing drugs. And the aim is to identify one or more drugs that are currently used in the clinic that can be repurposed to treat people with Prader-Willi syndrome. So we are absolutely delighted to welcome this group of talented and experienced scientists to our growing PWS community. Wish them every success with their work. Tony, thank you very much for joining us this evening and for sharing your project with us. Are you right to take control of the slides?
I think so. Can you hear me okay?
We can, yes.
It's just not sure how to get it into full screen mode.
So we're seeing full screen. Once you take control, you'll see a split screen.
Okay. I think I've got control now. So if you're seeing full screen, then that's good.
We are. Thank you.
Okay. Thanks a lot. It was certainly fantastic talk we've just had, and it's very hard to follow such a tour de force from someone who's such a fantastic expert with so much knowledge to offer everyone. But we are excited. This is going to be a fairly short talk. We're really excited to be able to do the research that because of the very generous funding from the Prader-Willi Research Foundation. And it's a new area for us. It's sort of not new type of research, but certainly a new disease for us to apply our research into. And hopefully we can make some kind of difference. Actually, how do I? Okay, yeah. So drug repurposing is a new sort of approach that a lot of people are looking at to try and speed up the treatment for a number of diseases. As you know, there's no cure for Prader-Willi syndrome. Drug repurposing is where you take drugs that are already out there in the clinic for other diseases, and there's many thousands of drugs out there that are used for a lot of different purposes. And you can look to see whether these drugs can be reused for other diseases. And this can cut down the time frame many years, and certainly a great big cost saving can be had and get drugs to patients faster, because you don't have the early stage clinical trials that you have to go through when you're developing a new drug that can take many years and a lot of trials to get through. And it's been some quite successful outcomes for this sort of drug repurposing in other diseases, so there's no particular reason why it can't be applied to PWS. So as you're aware, in addition to the hyperphagia, there are neurological changes and these can lead to various cognitive issues and so on, as we just heard. There's also a lot of evidence that there are changes to the brain cells and the way they interact with each other, the neural circuits. And this isn't just about things such as mental health and so on, although it does play a role in that, but it's also can control lots of other changes within the body. So, you know, it all sort of can stem at least partly from what's happening in the brain. And if you can alter that, then you may be able to reduce a lot of the other changes that you're seeing in people with the PWS. So what we've been doing is have a collaboration with Eske Dirks and Zach Gehring. And Zach is now at WeHi in Melbourne. And so he uses a computational approach to try and identify drugs that can be repurposed for other diseases. And the list on the left there is just a whole lot of genes that are known to be involved in Prader-Willi. And they have all sorts of different functions. And the names and so on aren't really important here. But the thing is that the genes that occur in any kind of disease, including Prader-Willi, they don't work by themselves. They work, all genes work as part of very large networks with interacting very quickly and sometimes quickly, sometimes slowly, with lots of other genes around them, all the proteins that they generate in a very complex network. So rather than just looking at what the genes do and targeting them, we look at the whole network that they're involved in, what we call co-expressed genes. And often we find there's many co-expressed genes that are involved in a lot of different diseases, but they're the same genes that come up. And it's not just the ones that are identified that are known to cause a certain disease. And then what we do is to match that with, there's a lot of databases out there on the way that drugs interact with certain genes and how, whether it'll increase that gene expression or decrease it. And therefore you can potentially target drugs that based on what out there already to not just the known disease genes, but all sorts of other genes as well. And we've done this with a couple of diseases already. We did it with Alzheimer's disease, and we identified some drugs that are out there in the clinic, and we put them through our systems, and they're looking quite positive. And we've also recently started work on Back disease, which is a form of childhood dementia, and using the same approach where we looked at the genes that are co-expressed with the Back disease genes, and then matched the drugs that are, interact with all of these other genes. We have a list of potentially 80 drugs that are out there that could be used, and we narrowed this down based on sort of a lot of other selection criteria down to 4 drugs. And the way we test these to see whether we have chosen the right drugs is by growing brain cells in culture from stem cells that we get from people with the disease. And so in this case, CLN3 is has a gene mutation that causes a form of Back disease, and you can also correct that mutation so you have cells that don't have the mutations, therefore don't have the disease-causing changes. And we can grow those into different brain cell types and treat them with the drugs that we've identified. And this is just an example of the sort of things that we've found with the Back disease. Cathepsin is a type of enzyme in brain cells that's very important for removing waste within the cell, and it builds up, and obviously it affects the function of the cells and the neurons. And we see lower levels of that in CLN3 form of Back disease compared to the healthy control cells. And when we treated the cells from Back disease with these drugs, we found that a couple of them are able to actually improve the levels of expression of the cathepsins, these important enzymes, and some other ones as well. So potentially, therefore, restoring the activity of these enzymes closer to what they should be. This inflammation is also important in a lot of brain diseases. It probably has a role in PWS as well. It seems to be involved in most diseases. not necessarily just because of inflammation alone, but because these cells that are known to be inflammatory cells have a lot of functions, a lot of different responses, and it doesn't take a lot to change them. And then if they change, they affect the way that neurons function. And we see that there's increased expression of these potentially toxic molecules from types of brain cells in CLN3. And if we treat them with the same drug, one of the same drugs again is able to inhibit the expression of these toxic compounds. So we're getting a couple of good changes that we're seeing in the cultures by using the repurposed drugs. And so now Zach is going to be looking at how the Prader-Willi genes interacting with other genes and proteins, and then identifying drugs that will potentially target them. And we'll be growing the cells from people with Prader-Willi and then testing the drugs on them to see how they go. So just in summarizing, obviously there's no major treatments at the moment, but drug repurposing is potentially a way of fast-tracking treatment of getting drugs into treatment for diseases like Prader-Willi. And the computational approach is really a way of speeding that up. So rather than just randomly trying drugs, it's a way of narrowing it down to identify which are the most likely drugs to work. And we've had quite good success in our work so far with other diseases. So we're hoping that we'll have the same kind of success with Prader-Willi. And once we identify those drugs, and we'll put them on the cells, and fingers crossed we see something very exciting that we can then start to look at moving into clinical trials. And just like to thank Lotta and Julia and Hazel for the work that you saw here, and also Zach, obviously, for the fantastic work with the computational studies. And thanks again very much to the Prader-Willi Research Foundation for the funding. It's fantastic, and we're really excited about what we could do. And that's it. Thank you.
Fantastic. Tony, thank you very much for sharing that with us tonight. Happy to take any questions you have on Associate Professor White's project as well. I think I'm really intrigued and impressed by the power that some of the computational approaches bring to speeding up the work and where it might go. I guess both with the computational work and the cell culture work, how does that there's multiple genes affected in Prader-Willi syndrome, and I imagine multiple potential pathways and interactions. Is that accounted for in the analyses that are done?
Sorry, I just missed the last bit.
So when they do all the network mapping, does it allow for interactions between potential medications or just between genes?
That's a good question. It's initially done with the genes, but yes, you can put in medications, and you can also sort of do it backwards. You can put in a medication or drug and then work backwards and see whether it could potentially target the genes as well. And so it works both ways. So it's slightly different process. Zach, I'm sure, would be happy to explain it, but yes, it can be done.
Yeah. And what's the next step from cell culture? Do you need to go through animal models, or is it possible to go straight to clinical settings?
I think it probably depends on the drug and what the targets are and so on. But because the drugs that we're using will already have been or already are being used in the clinic for other diseases, it's usually a matter of looking at whether you can do small trials. It will sort of also depend on doses and so on. I'm not sure that there's often a lot of value in sort of taking a step backwards to go into animals if the drugs are already known to be safe. So therefore, it's really about moving forward with them.
Fantastic. Well, I think that's very exciting news. We're all for anything that's going to accelerate us along these pipelines in a safe and effective manner. So yeah, we will watch this project, Tony, with great interest, I think, and report back as it progresses through the steps. So thank you very much for joining us this evening and sharing that snapshot. congratulations on the funding again. We're very excited to be involved in the project.
Thank you. Thank you very much for the funding.
Excellent. All right, I'm going to take control. Hopefully, there we go. Now, what we're going to move on to now is just a very short little snapshot. I guess some pieces of news that have drifted across my research desk in the last little while. So I'm going to start actually where we've finished off. So the first piece of news, it's still framed up around our research roadmap. So when I was looking at the treat pillar of the research framework, it's really the project you just heard. So the new funding that we've just announced to repurpose treatments. The goal, as you've just heard, is to identify drugs that are already in the clinic that can be used to treat PWS symptoms. And just to reiterate, what's so exciting about this is the powerful new, the tools, the computing tools that are being used, the potential for new insights and new targets, and accelerating that time to patients, which is just so critical. I think the other thing I'll highlight that we perhaps haven't touched on yet is that Associate Professor White and Dr. Gehring are both new to Prader-Willi Syndrome, which is one of the reasons we exist, to bring researchers who are incredibly talented into the field of Prader-Willi Syndrome and to get them to working on potential new therapies and treatments. The second piece of news I wanted to highlight sits under the transform pillar. So transforms around reactivating the genes. This news will be familiar to some of you. This is the venture capital funding that Professor Blewett has recently received. So We High Ventures have a fund, 6610, and they have awarded $5.6 million to Professor Blewett for her Prader-Willi project, which is, we're just excited beyond words about this, to be honest. The end goal for this project, so not the goal of the short-term funding, but the ultimate goal is to have a drug that will activate the silent genes. And we've got a number of resources we can point you towards for a bit more detail on that. But what makes this particular VC funding announcement really important is that it's supporting an Australian Prader-Willi researcher who's incredibly experienced. The Blewett Lab, they're all wonderful people who have done a lot to support new researchers as they move into the field. So having these experienced researchers helps create a really robust ecosystem for bringing new people in. Not to mention, of course, the amazing work they do themselves. The VC funding is also, it's a really highly competitive fund. So the fact that we've been able, or Marnie's been able to secure this funding is provides a really high degree of external validation around the work that she's been doing, and that's important. Obviously, the funding enables the next phase of development, and this sort of funding is really tightly tied to milestones, which drive release of the next step in the funding. So she won't get 5.6 million all at once. It'll be delivered in dribs and drabs as various milestones are met through the project. So that's exciting. This sort of support is really critical, because what we need to do with projects like this is we need to see them move from the discovery phase in the lab, which is where we started a number of years ago, through to a commercial product, and we're not quite there yet. And this step's often referred to as the valley of death, where projects fall over, they don't make it out of the lab. So VC funding like this is really important for progressing through that stage. And we also, both through the funding itself and through the results or the outputs from the funding, hope that this project will then be positioned to attract a commercial partner. And that's really important because of the amount of money that it takes to support the formulation of a drug, manufacture of that drug, and the clinical trials to test its safety and efficacy in people. The third piece of news from the research desk is the biobank, and we're really super excited to be in a position now to announce that the biobank is actually open for business. So we've been recruiting with your help. A massive thank you to all of you who've put your hand up to be involved. We've been recruiting for 2, 3, 4, almost 4 years now, and we have almost 40 people with Prader-Willi syndrome in the biobank now, and we've been able to now open that as a resource to the whole of the research community. So we've achieved the goal, which is to provide a data-rich resource for all researchers. What does it mean to be open? It means that researchers can now access those samples and the data that's associated with them. So the first application has already been reviewed. It's gone back for some minor revision, and we're expecting to be sending samples over to that new researcher in the very near future. There's also been a number of other inquiries, both from academic labs and from industry. So it's up, it's running, and it's being used, which is really exciting. This is important because those 40 individuals who volunteered their samples, those samples can now be used many, many, many times. So rather than people having to enroll in lots of trials, you can enroll once and that can be used many times. The biobank contains a really powerful combination of biological samples and clinical phenotype and associated data that's relatively unique and therefore of huge use to researchers as we unpack genotype and phenotype interactions. So what's driving the symptoms that you see? So this is a piece of infrastructure designed to extend research, to improve the research that's done, and to accelerate the research that's done. It's also a tool, a very powerful tool to attract new researchers and to enable new projects as they develop as well. And my last slide in terms of news, I always have to finish on clinical trials. Clinical trials are just so important for accelerating products through that pipeline. It's only through clinical trials that we find out ultimately if something is going to be safe and effective in the people it's intended to treat. So I know the text on this slide is very small. I can leave it up while we do some Q&A, but it's also available on our website. We'll be updating that over the next week. The main thing to remember with a clinical trial is to ask lots of questions, reach out to the study coordinator. Not every trial will be right for you. So if by asking those questions, you will find out whether it's a good fit and whether it's something you want to enroll in. But I would certainly encourage you to reach out, find out as much as you can, and help if it fits, if it's a good fit for you and your family. What I should point out here finally is that the clinical trial, it doesn't really fit neatly into any one of our boxes. It really encompasses the intersection, I think, between care, which is looking at how a health system delivers therapies, treat where we're targeting the most debilitating symptoms, and activate where we're making sure that we're developing the infrastructure to support, and in this case, support clinical trials. So that was the news that I had. I see we have a couple of questions. So hoping samples of people with Chapters-Yang syndrome can be included. That's absolutely a conversation we can have. It is the chromosome 15 biobank, and Chapters-Yang syndrome is a chromosome 15 disorder. So very happy to have that conversation as well. What else have we got here? So we have a question for Prof White, if you're still there, around the timeframes for computational analysis. Not sure if Tony's still here. We can certainly include that in the.
Yes, sorry, I just responded to that on the chat, but I'll just briefly say it's, we hopefully will have something within the next 12 months, but after that it's a bit difficult to tell because we don't know which drugs we'll actually identify yet. So that will inform a lot of what happens after that.
Excellent, thank you. And I see there's an answer there around the cord blood as well. The cord blood's an interesting question. I might also take that one back to David Godlow, who's running the biobank, just to see whether there's some potential uses for that as well. So thank you for raising that. I think that's a good question and a good thing to follow through on. Okay. If that's all the questions, then I'll hand back to Kath to wrap up. And I just add my final thanks to all of our speakers and to our audience tonight.
And look, Diane, let me thank you, and I hope everybody from everyone around the Zoom room can thank Diane as well. She's been with us for 8 years and really has been so instrumental in driving this enormous growth in Prader-Willi research. Diane, thank you so much.
Thank you.
Okay. And to wrap up, look, every November we run a giving day, and that is the day when obviously we're raising funds to try and make more research happen. As you've seen tonight, we are actually spending quite a lot of money with various researchers around the country, including Associate Professor White, and that really exciting project looking at repurposing drugs. Okay, personally, to me, that's one of they're also exciting, but that to me is personally one of my most exciting ones. Look, as I mentioned, since we came into existence, Prader-Willi research has grown a lot in Australia, and that's why we exist, purely to grow research into treatments and access to treatments for Australians. In 2016, Dr Webster and I did an audit of what Australian investment was happening in Prader-Willi research, and there was only $300,000. As you've seen tonight, since December of last year, there's been 6.5 million invested, announced investment into just 2 projects belonging to Associate Professor Godler and Professor Blewett. And both of those, we're so excited because both of those researchers are really doing work that's significant on the world stage, and they both came into Prader-Willi research as a result of some of the work we've done. So, you know, we really are delighted to see this growth happening. We measure our outcomes or how well we invest in projects using a multiplier, and to sum that up, we seed fund projects that we think have really good potential. We give them enough money to create some good data that they can then go out, and we work with them to attract more funding. So far, our multiplier is $24 times. So every dollar that we've spent on research, those projects have attracted, in total, the projects have attracted 24 times, $24 amount. So it's, you know, really a great measure, we think, of how well we are picking projects in which to invest. So if you are interested in getting involved and supporting us to keep doing this wonderful work, you can get involved this year in our Giving Day. Giving Day is the 15th of November, which is a Friday. It's very easy to participate. You can either just on the day share, and in the lead up, share our campaign and our link. We have a fundraising page. What I suggest at the moment is that, given that Facebook is really declining in terms of community, it's sort of going back to the future, isn't it? And it's becoming more about email networks and phone networks again. So, you know, really engaging your networks, your families, your communities, your friends to support our work would be fantastic. If you want to do more than that, you can actually set up a team. And to set up a team, you just send a photograph and a short story about why you want to fundraise for Prader-Willi research to Nicole, and you can see her email address is there. Or if you're just interested in getting more information about how to go about Giving Day, you can just request a team brief from either myself or Nicole, and we can send that to you. We'd love to get as many people involved as possible. We are aiming to raise $100,000, and we've got a very wonderful donor who has offered to match that money to $100,000. So we're very much hoping that we can get our community excited about, once again, raising money to drive more and more of this wonderful work that we are investing in. And then I just want to say thank you to everybody that's here tonight, all of our wonderful donors. Just thank you for making all of our work possible. We take it very seriously, and we're very committed to delivering new treatments, either through research or access to our wonderful community here in Australia.